Hi, welcome to the ERMP and Beyond channel. We have been discussing on the 2021 ERMP recall questions. Today we will discuss on case number 12. A 35-year-old male with painful scoliosis came with a complaint of back pain, which is not relieved by use of salicylates for months. Thoracolumbar X-ray revealed a well-defined, mildly expansile sclerotic lesion over the spinous process of T12. What is the most likely diagnosis? A. Metastasis. B. Osteosarcoma. C. Aneurysmal bone cyst. D. Osteoblastoma. The key pictures to help us to narrow our diagnosis are presence of aspirin-resistant back pain, scoliosis, and presence of well-defined sclerotic lesion on X-ray. Let's explore each option in detail. Metastasis spinal tumor is a common cause of sclerotic spinal lesions, especially in adults over 40, and is often associated with cancers that have a propensity to spread to bone, such as breast, prostate, lung, and kidney cancers. However, the patient's younger age and the description of a well-defined lesion makes this less likely. Osteosarcoma is the most common malignant primary bone tumor and is highly malignant. It is most common among people aged 10 to 25, but it can occur at any age. There are two peaks of incidence. Incidence is highest in adolescents and young adults, coinciding with adolescent growth spurt, and secondary peak occurs in adults older than 60, especially in those with risk factors such as Paget disease, bone infarcts, and previous exposure to high-dose radiation therapy. There is a genetic predisposition, especially in children who carry the gene for hereditary retinoblastoma, variants of RB1 gene, and Li-Fraumeni syndrome resulting from mutations in TP53 gene. Osteosarcoma produces malignant osteoid, which is immature bone from tumor bone cells. Osteosarcoma usually develops around the knee, at distal femur more often than proximal tibia, or in other long bones, particularly the metaphyseal diaphyseal area, and may metastasize to lung or other bone. Pain and swelling are the usual symptoms. On imaging, the tumor may show a characteristic sunburst pattern due to the aggressive growth of the tumor into the surrounding soft tissue, creating a radiating appearance. Additionally, a Codman's triangle may be present, which is a subperiosteal elevation that forms a triangular area. This is caused by the tumor lifting the periosteum away from the bone. Osteosarcomas can also exhibit mixed lytic and sclerotic lesions with poorly defined margins, indicating both bone destruction and reactive bone formation. These radiographic features are indicative of a high-grade aggressive tumor and are essential for the initial diagnosis and planning of treatment. Note that while these findings are suggestive of osteosarcoma, a definitive diagnosis requires a histological examination. Patients need a chest X-ray and CT to detect lung metastases and a bone scan to detect bone metastases. MRI is done of the entire involved extremity to detect metachronous lesions if present. PET-CT may show distant metastases or metachronous lesions. An aneurysmal bone cyst is a benign but potentially aggressive bone lesion that typically affects children and young adults under the age of 20 with no gender predilection. Clinically, patients with ABC present with localized pain and swelling, and in cases where the spine is involved, symptoms related to nerve root compression may occur. Complications from ABCs, including pathologic fractures, nerve compression syndrome, and in spinal cases, canal stenosis. ABCs consist of multiloculated blood-filled spaces separated by fibrous septa, and they are surrounded by a thin reactive bone formation rich in multinucleated osteoclast-like giant cells. These lesions are typically located eccentrically in the metaphysis of long bones, adjacent to an unfused growth plate and in the spine, although they can occur in almost any bone. The diagnosis of ABC usually involves imaging such as X-rays, kinetic scans, and MRI. Imaging studies often reveal a multicystic bone lesion with fluid levels, a hallmark of ABC. Biopsy is essential for confirmation, where the cyst walls are found to be composed of fibroblasts, osteoclastic giant cells, and hemosiderin pigment, along with evidence of new bone formation. Osteoblastoma is a rare, benign bone tumor that typically affects individuals between the ages of 10 and 30, with a higher prevalence in males. The tumor arises from osteoblast, which are responsible for creation of osteoid tissue. Osteoid tissue is weaker than normal bone tissue, making bones more susceptible to fractures. Osteoblastomas are most commonly found in the posterior elements of the spine, hands, and legs. It is similar to osteoid osteoma but is larger in size and grows progressively. Pain is the most common presenting symptom. The pain is usually less severe and less pronounced at night, and not relieved by aspirin compared to an osteoid osteoma, in which night pain is particularly severe and the pain is usually relieved with an aspirin. Spinal lesions may be accompanied by muscle spasms and scoliosis. Characteristics on imaging area: well-circumscribed radiolucent nidus of 2 to 10 cm in size, surrounded by sclerotic zone. There is distinct demarcation between the nidus and reactive bone. Given the age of the patient, the clinical and the radiographic features of the lesion, an osteoblastoma is the correct answer. Thank you for watching.